We are live.
Okay. Dr. Devasis.
A very good evening to all the EIZOC members we are having in the webinar today. This is to introduce the 37th Ophthalmic Residence Teaching Series, which today's topic will be Pupillary Pathways. We are indebted to Dr. BNR Subudhi for conducting this webinar over the years together, and now it has reached the dimensions where people ask for the webinar, and not that we are only arranging the webinar, people wait for it and attend it. I welcome our mentor, Dr. Ajit Babu Majji. I welcome our Chief Coordinator, Dr. BNR Subudhi, and our Coordinator, Dr. Sabyasachi Patnaik. I welcome our speaker today, Dr. Virendra Sachdeva, who will be speaking on the Pupillary Pathways. This session will be moderated by none other than the dynamic Dr. Tripti Kauntia. We have a galaxy of panelists in the names of Dr. Archana Kumari, Dr. Ranjana Kumar, Dr. Arundhati Tamuli, Dr. Bhatriti Walang, Dr. Sweta Dhiman, Dr. Amit Kumar, and Dr. Haimanti Chaudhary. We have our postgraduates and juniors as discussants. With this, I hand over to Dr. BNR Subudhi for further consideration of the webinar. Over to you, sir.
Thank you very much. I welcome Dr. Jayant Borua, our president, to speak few words. Dr. Jayant ji.
Good evening. Good evening, everyone. Am I audible?
Yes, sir, you are audible, sir. Please go ahead.
Very good evening to all. I welcome you to this seminar, which we have been, people from all over the east have been missing for quite some time. I thank Dr.
You are not audible now.
Am I audible?
Now it's audible. Yeah, you are audible. Yes.
Okay, let me. Okay, let's. So first of all, I again apologize for my delay in joining the meeting today, and let's. I pass it on to Dr. Sorry.
Okay.
Hello.
Thank you, sir. Thank you.
Sorry.
I welcome you all to this EIZOC series ORTS 37, and today's speaker, as I already said, Dr. Virendra Sachdeva. I will speak into Pupillary Pathways. I will not repeat all these things already told by Dr. Devasis. So I will go to our posted students who will be participating in this webinar. Dr. Shraddha Satyapradar, JPM Rotary Hospital, Dr. Saptarshi Mukherjee from Bankura, Kolkata, Dr. Anamika Chaudhary, and Dr. Zahid Asra from RIMS Ranchi, Dr. Nahid Javed from SC Medical College, Cuttack, and Dr. Survi Prasad from Silchar Medical College, Assam, Dr. Pragya Bharati Nanda from Bhimsar, Burla, and Dr. Akshay Kumar and Dr. Mohandas from AIMS Patna, Dr. P. Subhasri from MKG Medical College, and Smriti also from Medical College, MKG Medical College, and Dr. Priyanka and Dr. Saki from Ruby Eye Hospital, Barampur. So all these postgraduate students, I welcome you all for this interaction with our speaker, moderator, and panelists. Please come with the video and ask questions and answer the questions too. So with these few words, I thank you everybody joining this webinar. And once again, I welcome you all to this webinar, all the viewers also. Now it's over to Dr. Tripti to introduce the speaker and proceeds.
Good evening all. I welcome Dr. Virendra Sachdev for his talk today on pupillary pathways. As we all know, sir is a consultant and heading the neuro-ophthalmology services at LVPI network. He did his post-graduation from the University of Delhi and did a comprehensive pediatric ophthalmology and strabismus with neuro-ophthalmology fellowship from LVPI. And then another esteemed fellowship from Emory University, USA. His main areas of interest lie in optic neuritis, imaging, idiopathic intracranial hypertension, CSVT, myasthenia, and complex strabismus. Sir has more than 90 publications and he has written 16 book chapters. So we are all waiting eagerly, sir, to hear from you. Please welcome Dr. Virendra Sachdev for his talk.
Thank you, Dr. Trupti. Let me begin by thanking all of you for giving me an opportunity to speak to the EIZOC members as well as the postgraduates. I think pupillary evaluation and pupillary pathways form an important integral part of our day-to-day practice. And I will be trying to cover up in such a way that it benefits both the clinical aspects as well as the postgraduates towards their examinations. So I do not have any financial disclosures pertaining to this talk. Let me begin by saying that in neuro-ophthalmology, we do a comprehensive evaluation and a lot of things are integral part of evaluating a patient with either an afferent or an efferent pathway disease. So we do the evaluation by looking at the fundus. At times we take fundus photos. We do the cranial nerve testing. We do pupillary testing. We obtain visual fields and OCT. Among these, pupillary testing forms a central important aspect because they are at the cusp of both afferent pathway disease as well as efferent pathway disease. So if there is a path abnormality either in retina, optic nerve, and the anterior visual pathways, it can lead to a pupillary abnormality. And similarly, if there is an abnormality of the third nerve function, it can contribute to an abnormal pupillary reflex. So that's why it's important to check for the pupillary abnormalities. So when we talk about pupillary evaluation, what all we document, this is always a little different. Every person tries to document in a little different way. However, if we pay attention to this talk, maybe we can get to a uniform way of documenting this. When we are doing the pupillary evaluation, we record a lot of things. For example, the pupillary position, pupillary size, pupillary number. We look at the pupillary response to light accommodation as well as to the convergence that is happening. We are always looking for a relative afferent pupillary defect. But is it just checking for the relative afferent pupillary defect? Is that enough? Possibly no. I'll try to highlight this aspect in the course of the talk. We also need to sometimes see that whether it's RAPD or EPD. If it is there, then how do you evaluate the patient with the pupillary response abnormality? I'll again try to highlight in the course of the talk. And there are times when the pupillary sizes are different. We call that anisocoria. So how do we evaluate a patient with anisocoria? These are some of the things that will be highlighted in this session. As I was trying to say that people lies at the amalgamation of afferent and efferent pathway abnormalities. So that's why pupillary function is very important. It can help localize the lesion to anterior visual pathway, or it could help us find that it's an efferent pathway defect. So let us begin by revising where the pupil is, what is the basic structure of it, and what is the innervation. Then we go to the physiology, and then we look at the evaluation of the pupil. We know that pupil is basically a small central aperture in the iris that helps controlling the amount of light that enters the eye as well as helps in accommodation. Basically, this is all controlled by the muscles which are in the iris. And what we are seeing is a change in the size of that aperture. So in the normal light, it is a mid-sized, maybe somewhere about 2 to 4 millimeters. In the iris, close to the central aperture or the pupil, we have the circularly arranged sphincter pupillary muscles, and we have the radially arranged muscles which are outside, extending from the sphincter pupillae to the periphery of the iris. So these radially arranged muscles are the dilator pupillae. In the bright light, we know that the sphincter pupillae constricts and the pupil becomes smaller. And in dim light, the sphincter pupillary muscle relaxes and the dilator pupillary muscle actually constricts, leading to a dilatation of the size of the pupil. Again, all of us do know that the intrinsic muscles of the eye have specific innervation. The sphincter pupillary muscle that constricts the pupil is getting a supply by the parasympathetic nervous system, which is reaching to it through oculomotor nerve and through the ciliary ganglion. I will again highlight it in the course of the presentation. The dilator pupillary muscle actually dilates the pupil, gets its innervation from the sympathetic pathway, and we will discuss the pathway in the subsequent course of the presentation. There is another thing that does happen as part of the near reflex, which is constriction of the ciliary muscle. This ciliary muscle is not directly involved in the pupil, but at the same time, it causes a change in the shape and the power of the lens, which we call as accommodation. Why it is important to know that? Because it has a similar innervation as a sphincter pupillary muscle, and this action occurs as a part of the near triad or the convergence or the accommodation reflex. So we'll be with this, we will be covering in more detail the course of the presentation. We'll be discussing the anatomy and physiology, the pupillary reflexes, abnormalities of the pupillary reflexes, anisocoria, and little bit about the drugs that are used to evaluate the pupils. So I briefly highlighted that pupil is a single aperture that is present in the center, usually just slightly nasal to the center of the eyeball, and the function of the pupil is to control retinal illumination, reduction in the optical aberrations which might happen with a very large pupil, and to help us arrange in the changing the depth of focus while doing accommodation. Normally it's a single pupil, but there are few instances where there can be multiple pupils. This could be a true this is called as polychoria, and this could be a true polychoria wherein an extra pupil is there, which is equipped with sphincter muscle that contracts on exposure to light. So it is basically a developmental anomaly which occurs wherein multiple small segments of the iris apertures form, and each of them is surrounded by a sphincter pupilla. Whereas a pseudopolychoria occurs as an aperture in iris without separate sphincter muscles. Most of the time, pseudopolychoria is secondary to a degenerative process that occurs in the iris. So let's see a few images. So this is a image that is of a true polychoria, wherein we can see that multiple apertures have been formed over here apart from the central sphincter pupillary muscle. And this is an example of a pseudopolychoria which has occurred secondary to a large trauma to the iris over there. This could be a surgical trauma or a blunt trauma to the iris. The pupillary size is influenced by a lot of factors. The most important being the amount of the ambient light which is there in the surroundings. It also depends on the state of retinal adaptation, the level of arousal and awakeness of the patient. Sometimes with age, pupillary muscles become less responsive and the patient might have a senile meiosis. We can assess the size of the pupil by using a device called as pupillary gauge. It is basically a scale-like device on which the different sizes of the pupillary diameter are mentioned. So like ranging from 2 mm to 9 mm. And there can be a small torch on which also it can be there. That helps in assessing the size of the pupil. There can be, as I was telling briefly, that it can be affected by many things. So for example, physiologically, during sleep, there is lack of the inhibitory inputs that are coming. Therefore, the parasympathetic pathway gets overactivated and leads to a reduction in the size of the pupils. Extremely small pupils might be seen in diseases such as pontine hemorrhage, pilocarpine use, and narcotic intoxication. So, pontine hemorrhage associated with small pupils is an important sign that is used in neurology, and we should be aware of it. Sometimes some patients might have extremely large pupils, which are poorly dilating to the poorly constricting to the light. So that indicates that the parasympathetic pathway is blocked. It could be due to some drugs, for example, dilating drugs most commonly, and sometimes drugs which are stimulators for the which are blocking the parasympathetic pathway. Sorry, for example, scopolamine, which are used, for example, to avoid the motion sickness. There could also be larger people in a state of anxiety and by after using certain stimulating drugs. So let's see certain abnormalities of the pupillary shape that can occur. Normally, the pupillary shape is round. So what do you think, the postgraduates? What is this example of? Can somebody take it? So this is a pear-shaped pupil. You can see that superiorly the pupil is fairly round and inferiorly you cannot see the pupil. What is this? I think most of you have seen these examples in your clinics.
Dr. Pragyan Bharti. We need to call by name, then only they will respond. Otherwise,
Sorry,
they
I
will
do
not
not know
respond.
their names.
Priyanka, bolo.
Dr. Shraddha.
Beta is panelist.
Sir, Iris coloboma.
Iris coloboma.
Very good. This is an example of a iris coloboma, and you see a pear-shaped pupil. So you can see that inferiorly the iris is missing. As a result of it, the pupil is pear-shaped or keyhole-shaped pupil that might be seen. This is an example of a patient with aniridia. You can hardly see that there is a small remnant of the pupil that is visible, and you can actually see that entire lens is visible, and you can see the zonules which are attaching to the lens. You can easily make it out over there. Okay, you can see these zonules which are present over there. This is a now what is the third figure over here?
Iridodylasis.
Very good. So this is a D-shaped pupil that is occurring due to the large iridodylisis after a blunt injury, and you can see that the iris is separated from its root on the temporal aspect of the eye. And this is a patient with a
Pupil.
festooned pupil, secondary festooned pupil. So these are the.
What is the cause? What is the cause from the pupil?
Case of uveitis with a posterior syringia.
Very good.
Very good, excellent. So these are some of the other causes, which some of the abnormalities in the shape of the pupil. If you notice this, most of these are secondary to the mechanical problems, either in the development or damage to the muscles of the eyeball or iris. So that can, but these are possibly not related to the neurological causes that we'll be covering in the subsequent sections. Okay. So normally, what is the color of pupil? Normally the pupil appears as gray-black due to internal reflections that happen from the retinal pigment epithelium, posterior pigment layer of iris, as well as the reflection from the lens area. So if there is any abnormality in the lens and the retina behind it, we may get a whitish reflex, for example, in patients with retinoblastoma, cataract, PHPV, Coats disease, and even large toxocariasis. Some of the pupillary color abnormalities are of neurological significance. So we have two major abnormalities wherein the color of the iris is different in two eyes. We can see that there is a brown color iris which is present in the left eye and a much lightly pigmented bluish looking iris which is in the right eye. It is a heterochromia iridis. And sometimes it is within the same eye, the color of the iris is different. We can see a sector which is darkly pigmented while rest of the sector is lightly pigmented. It is called as heterochromia iridium. So why is it important in relation to the pupil? Because heterochromia iridis can be seen in patients with sympathetic pathway abnormalities, especially Horner syndrome. And which Horner syndrome? Only in congenital Horner syndrome, because at that time the pigmentation of the iris requires a normal presence of the sympathetic pathway. If it is abnormal, the pigments are not formed and released over there. Okay. So we will just briefly look at this aspect, that what all we need in the evaluation of a pupil before we go into the pupillary pathways. So what we need is usually a dark room or a semi-lit room wherein the illumination is relatively low and can be controlled. We can keep a light source above the head of the patient, and we need a bright light source, for example, a focused pen light, or you can also use a good indirect ophthalmoscope also. We can use a scale or a pupillary gauge, which can be either a separate scale-like thing or can be printed on the side of a torch. And then we have something we call as neutral density filters. So if you see this bar which is there, it contains photographic filters which are going to reduce the amount of light that enters the pupil. So these are of varying depth. The lightest one is on the top and the greatest is on the bottom. They increase in the density by 0.3 log units. So you keep it in front of which eye, good eye or the worse eye?
Yeah.
Maybe
Priyanka, you can answer.
Yes.
See, it's to measure the RAPD. So which eye you will
Like to keep.
like to keep so that it will match the other eye? Is it abnormal eye or normal eye?
So it is kept in front of the normal eye so that the
Normal.
light intensity that is going would
So
get
that-
reduced. So the response from the good eye would also start matching the abnormal eye. Okay. I'll come back to it a little bit again when I am trying to tell the clinical assessment of the relative afferent pupillary defect. Okay. So let us cover a little bit more about the pupillary pathways, which is the main title of the today's talk. We are going to discuss and talk mainly about the light reflex, accommodation reflex, a little bit about the darkness reflex. So this is a very important figure, which I think all of you have seen in your textbooks and many of you might already be knowing. I would try to simplify this figure so that everybody can remember it. We know that the vision pathway carries both the images that what we are going to see as well as the light rays for mediating the pupillary pathways. So they are three order neurons. That is the normal arrangement which happens in the central nervous system. The first order neurons, they start from the retina. So they are the retinal ganglion cells, and the axons of the retinal ganglion cells pass posteriorly to form the optic nerves. The optic nerves run posteriorly. There is a partial decussation of the nasal fibers that happens in the optic chiasm, and the temporal fibers continue posteriorly, and they together join to form the optic tracts. So we know that the visual pathway is going to the lateral geniculate body, and from there the pathway is going to the occipital cortex. However, the pupillary reflex pathway that is mediating the light reflex leaves the optic tract and joins the brachium of superior colliculus and enters the midbrain. In the posterior portion of the midbrain, it synapses with the neurons which are present in the pretectal nucleus over there. You see this this oval structure which is on either side on the posterior midbrain. This is called the pretectal nucleus. These fibers pass to the ipsilateral pretectal nucleus. From there, the neurons would go and they would go to the second side pretectal nucleus as well, and then pass second order neurons. These are called as internuncial neurons. Then from the pretectal nucleus, the second order neurons will start and they will go into the Edinger-Westphal nucleus. This Edinger-Westphal nucleus is a subnucleus of the third nerve nucleus or the oculomotor nerve nucleus, which is the site of the origin of the motor pathway for the pupillary reflex. What is important is that there are few exceptions which have happened until here. The pathway for light reflex is not going to the occipital cortex. It is going directly to the posterior midbrain. And then in the posterior midbrain, the fibers are going to the both sides of pretectal nucleus and both sides of the Edinger-Westphal nucleus. So even when one eye will be stimulated, like right eye stimulated, the fibers will be going to both sides because there is a interneuron that is going to both sides pretectal nucleus and to the both side Edinger vestral nucleus. From the Edinger vestral nucleus, we see the efferent fibers which are starting. They are coming out in the substance of the midbrain. Then they exit out, join the third nerve, and run through the pathway of the third nerve. And then they will reach along with the third nerve, along the branch to the inferior oblique muscle to the ciliary ganglion. Over there, synapse happens, and the short ciliary nerves will be generated, and they will run to go and supply the sphincter pupillae muscle. So these are certain important landmarks that we need to know. And what I stressed out to all of you was that there is a bilateral innervation. So what is the implication of that bilaterality? Even when we are stimulating one eye, you are going to see a response in both eyes. We call the response that is happening in the eye which is stimulated as a direct response. And the response that we see in the contralateral eye is called as a consensual response. So as you see in this picture over here, when we are stimulating the right eye, there is constriction of the pupil in the right eye as well as left eye. So right eye response is the direct and left eye response is the consensual response. Now let's see the sympathetic fibers that are going to be seen. So the sympathetic fibers take origin from the hypothalamus. From the hypothalamus, the first order neurons, they arise, they run down the brainstem all the way in the periventricular or the periaqueductal area, then in the periaqueductal gray matter, they are running below in the midbrain, then in the pons, in the reticular formation, and then they run in the area around the central spinal canal in the spinal cord all the way till the till the T1 and C8 area in the spinal cord. Over there, they synapse with the second order neurons which arise from the C8, T1, 5 areas of the spinal cord. They run out and then they join and then they run upwards in the sympathetic chain over there. They come to lie at the level of the superior cervical stellate ganglion, which is at the level of the C1 and C2 levels of the spinal cord. From here, the third order neurons will arise. These will go and they will run around the carotid artery. First around the common carotid artery and then around the external and the internal carotid artery. The fibers which supply the pupil will keep on running around the internal carotid artery and they form a plexus around it and they come and supply the pupil through the long ciliary nerves. There is something again important over here. These sympathetic fibers which are arising from the third order neuron, which are forming the third order neurons arising from the superior cervical stellate ganglion, they are supplying not only the pupil but to the sweat glands of the face, to the smooth muscles of the eyelid, okay, the Muller's muscle, to the sweat glands of the forehead. So it is going to actually give multiple innervations. So if there are lesions to the sympathetic chain over there or sympathetic fibers, we are likely to see multiple findings. If there is a decrease in the sweat glands of the forehead, you will see reduced sweating over there. There is a smooth muscle damage of the eyelid, we will see a partial ptosis. Due to the pupillary damage, you will see a lesser pupillary dilatation and the constriction will happen because the sphincter pupillae is going to take over and we will see a meiosis and we will again see a lesser sweating on the face, which is called as anhidrosis. So these are
What is this syndrome?
Horner
Horners.
syndrome.
Horners.
Horner
Yeah.
syndrome.
Yeah,
Horner
yeah, nice.
Thank you, sir. So this all constitutes the spectrum of the Horner syndrome. Okay. So this image summarizes or simplifies the pathway very much. To the left side of the screen, we have the sympathetic pathway, which we just discussed. First order neuron is starting from hypothalamus, runs down to the ciliospinal center of perch in the CA to T1 area. Second order neurons enter the cervical sympathetic plexus and the superior cervical sympathetic ganglion. At that level, the third order neuron arises and runs along the internal carotid artery, and then they will supply the the dilator pupillae. Whereas the parasympathetic fibers, the efferent pathway is starting at the level of midbrain, Edinger vestral nucleus. From there, it goes to the oculomotor nerve, now to the inferior oblique, and then in synapses in the ciliary ganglion. From there, it runs on the short ciliary nerves to supply the sphincter pupillae muscle. So this is a very simplified diagram that you can keep in your mind and that can help you remember it for always. We discussed that there is constriction to the light, there is a dilatation to the darkness because of the sympathetic fibers. So these form the light reflex and the darkness reflex. There is one more reflex that we were talking briefly, is the accommodation reflex pathway. The accommodation reflex pathway is slightly different. In the accommodation reflex, the light rays which are starting from the retinal ganglion cells, they are again carried in the optic nerve. Then they join at the optic chiasm, partial decussation happens. They run in the optic tract, and then they would reach actually the visual cortex. And from the visual cortex, then the fibers run downwards to reach the midbrain, again at the level somewhere in the Edinger vestral nucleus area, from where the accommodation center is believed to be located. And then these fibers will run forward in the oculomotor nerve. These will be maintaining, these will be going and supplying the sphincter pupillae. They will also be supplying the ciliaris muscles over there. So as a result of that, what we discussed before, there will be not only pupillary constriction, but also the change in the power of the lens that helps us in focusing for the near. So this is the accommodation reflex pathway. Okay. So in the near reflex, what happens? When we are focusing at a near object, the image comes over there. What we are seeing is that these fibers are taken by the optic nerve to the optic tract, to the lateral geniculate nucleus, to the optic radiation, to the visual cortex. And then from the visual cortex, there are fibers that are actually going into the frontal cortex that are going to Edinger vestral nucleus, and then also to the motor nucleus of the third nerve. The Edinger vestral nucleus is helping in the pupillary constriction lens thickness, and the cranial the frontal cortex is actually also giving fibers to the motor nucleus of the medial recti, and that causes convergence. So this forms the basis of all the three components that are happening: pupillary constriction or meiosis, lens thickness change or the accommodation, and convergence, which are all part of the near reflex. So if you understand, the difference is in the light reflex, the fibers are going directly to the midbrain through the superior colliculus, whereas in the near reflex, pathway is going first to the occipital cortex, from there to the frontal eye field, and from there it comes down to Edinger vestral nucleus as well as the medial recti. Okay, so let's see. This is an example of what happens in the near reflex. So this is infrared imaging that you can see. As a result of that, we can see the pupillary responses much better. I'm thankful to my colleagues for helping sharing this video for the teaching purposes. So this is a person is focusing at nearby. You can see convergence is happening. And then at the same time, you can see pupillary constriction is also happening. We can see these two changes obviously in this patient. Okay. So if we have to look at the examination of the pupil, this is coming back to one of the first few slides that we were discussing, that what all you will evaluate in a patient. You will look at the anatomical aspects, number of pupils, the shape of pupil, and then the pupillary reactions analysis will start. We are going to look at light reaction, we are going to look at accommodation and the convergence response which is happening. And keep in mind that pupillary responses are bilateral, so we want to check for the direct response as well as the consensual response. We also briefly discussed what are the prerequisites. So you need a dark room. Why do you need a dark room? Can somebody tell me? What will happen if we are doing the pupillary testing in a bright room? What will be the pupillary size like in a bright room?
To avoid any false results.
Okay. So in a bright lit room, the pupil size would always be a smaller one because the light condition is already bright. So people will be smaller. So it is difficult to see the response in these patients with the relatively small people. We want the pupils to be of a medium size. So that's why if you keep a dark room, it's easier. But then you ask the patient to look at a distance target. What we typically tell the patient is to look at the vision chart, which is there at the 3 meter or 6 meter, depending on the size of room. Why is it so?
Because when patient is
Clarification of
looking at
pupillary muscle.
near, his pupil is already constricted.
Yes, so if the patient is looking at a near target, then the
Convergence reflex is there,
yes.
no? Just now he has showed.
So if we are looking at a near target, already the patient might be using the convergence or the accommodation reflex, and as a result, people might be small. So therefore, it will be not appropriate to start testing there. We use a bright flashlight. Okay, it's a focused light that is ideal. We also use actually indirect ophthalmoscope at times, but it might be better to use a bright flashlight. One of the ideal sources of light is something which we call as a pupillary illuminator. It's something like our direct ophthalmoscope base, and on the top of that there is a R-shaped area which is going. So it gives a very focused light. It is called as a illuminator. Welch and Company makes it, and it is frequently used in neuro-ophthalmology clinics in the Western world. So ideally, possibly two light sources might be required. First, a bright flashlight, which is like an indirect ophthalmoscope, and then a diffuse light source. Okay, why I'm saying two light sources might be required? Because you are already using a dim room. You keep a diffuse light source, such as a big torch, towards the chin of the patient or towards the forehead of patient, that is helping us see what is going to happen from there. And you use a bright flashlight like an indirect ophthalmoscope, Welchel illuminator, or use a bright pen light torch over
It
there.
should be a pencil of light so that it will be more focused rather than a diffuse light.
Yes, thank you, sir, for pointing out. So that's very important. That's why we say bright flashlight, which is giving a collimated beam of the light. Okay, so we discussed these are the things that we need. One important pearl that you can remember is that the light source for the pupillary avulsion should be bright. It should be without a central scotoma. Indirect ophthalmoscope is considered as one of the best sources. You can see the image to the left with the tick mark shows that how the light should be, and the image to the right side with the dark area in the center tells that your torch light should not be fogged in the center. So this is how you can keep in mind. Okay, so we will discuss how do we check, what is the technique for checking the relative afferent pupillary defect. So just before that, I would like to stress one thing. What is the meaning of relative afferent pupillary defect? So again, I would like to ask you people, what do you mean by the word relative over there? So maybe,
Sakshi.
yes.
Sorry, sir, can you repeat the question?
Relative afferent
Huh.
pupillary defect.
So
We are
we
all
are
fond of
seeing
using the term RAPD. So what is the meaning of each term? What is relative over there?
relative, like we are seeing a reaction of one pupil in comparison to the other pupil. So that is relative here.
Yes.
Excellent. So that is the meaning of this. So if suppose both eyes are abnormal, would you still get RAPD? So if suppose both eyes are having only light perception vision, we may not see a RAPD, but we might see a afferent pupillary defect in the sense that pupils are not constricting to the light. So this is important for all of us to remember. Many a times in the exam, the examiner is fond of asking that what is meaning of relative over there, and what would happen if there is there is a bilateral afferent pathway abnormality. So over there, we will get a poor response to light. People are mid-dilated, they are sluggishly reacting to light. Okay, coming back to how do you check for the relative afferent pupillary defect. So the way to check for it is, again, we use a swinging flashlight test. So it is also what we do is that we ask the patient to look far away. We will stimulate one eye at a time, and we will then switch the light stimulation to the other eye. So how do you do it? You'd stimulate, say, the right eye, as shown in the example over here in the picture. You are stimulating the right eye first, and you see that response is happening in both eyes. Then you take the flashlight to the other side, and then you see the response is not happening in both eyes. In the figure B, you can see that there is pupils are large in both eyes, and then again you shift back to the right side. You can see pupils are again constricting, suggesting that when the right eye is being stimulated, you are getting a response in both eyes, direct as well as concentric. Whereas in the stimulation of left eye, you do not see the response in either eye. Again, suggesting
So which eye is abnormal here?
left eye is abnormal, and that has the relative afferent pupillary defect. Okay, so there are certain important things that are of practical utility that I would like to share here. So let's see this video, and then I will share those points. So this is a light which is being used to stimulate first the right eye. Pupil is constricting, and this is the left eye. We see that pupil is actually dilating. I'll play this video one more time for all of us to appreciate. You see that left eye, as you take the light from the right to left, it is dilating. So this is a relative afferent pupillary defect in the left eye, what we saw in the previous picture also. So if you would have noticed in this video, the light is being taken from below the chin of patient. We are not swinging the light directly from right eye to the other eye across the nose of patient. To avoid this, actually, what you can do also is that you can keep your hand in between the two eyes, and then you can do the swinging flashlight test. Then what will happen? That the light from the right eye is not going and stimulating the left eye simultaneously, and you would avoid a false negative response. This will be important when the pupillary reflex, when the RAPD is small or a grade 1 like that. Okay, so the other thing that is important is that how do you swing? How many seconds you stimulate one eye and then you stimulate the other eye? Many a times this is the examiners are very fond of asking it. So we use a 3-second cycle. How do you know it is 3? Is it 1 to 3? Is it 1 to 3? Is it 1 2 3? How do you titrate it? Can anybody answer that? So one of the standard techniques of teaching is that you do is you calculate 1 1000, 2 2000, 3 3000. Like that, if you do, that is the adequate time that is being taken. So you speak like that in your mind, simulate the right eye, then take to the left eye. So that way you will be using a standard technique that is described to do it. The next question that comes is that if you pick up a relative afferent pupillary defect, then what does it do? You grade it? Can you grade and find the severity of it? We saw that in this patient, as you are simulating the right eye, there is constriction, and as you take to the left side, there is a direct pupillary dilatation. It is very easy to detect. We call this as a pupillary escape phenomena, and it is suggestive of grade 3 relative afferent pupillary defect. Now, Bell provided a grading system wherein he provided 5 grades. The grade 1 is that small constriction followed by greater dilatation. So we will see that there is a constriction, but at the same time, it will be followed by a dilatation which is bigger. Grade 2 is you see a brief stall in constriction followed by dilatation. What it means is that it will appear that pupil is constricting, but it doesn't constrict fully. It doesn't become totally small, but it immediately starts dilating. And in the grade 3, you see a direct dilatation, what we saw in the previous video. After you see a greater dilatation, then comes grade 4 and 5. Grade 4 means pupillary dilatation on stimulation of the normal eye for more than 6 seconds. So what it means, like in this previous example of left eye RAPD, you will you picked up that the pupil is dilating directly. Now what do? You stimulate the right eye for 6 seconds. By doing that, the response from the right eye would become weaker because the retinal pigment epithelium will get blanched over there, and then again you do the swinging flashlight test. And then if after doing the swinging flashlight test, from taking the light stimulus from right to the left eye, at that point of time, the pupil starts becoming narrow, smaller, then it is grade 4. If it does not, then it means that it is still grade 5 or a total afferent pupillary defect. So this is the Bell's grading system. This Bell's grading system is little subjective. It varies from person to person, but it is fairly applicable. So let's see this example. This is an example of a lesser grade of RAPD. So let's see carefully. We can see that the right eye pupillary response is brisk. You can see a small constriction followed by a greater dilatation in the left eye. So this is a patient with a grade 1 RAPD. So with careful meticulous evaluation, it is actually possible to apply this and use it. There are few other objective methods of using it, wherein what we can do is that we can actually use the neutral density filter. So we saw this picture before also. I will tell a little bit more here. What we can do is that when we are suspecting a subtle RAPD, look at other things also. Look at the first response of the patient and compare the speed of constriction. So if the first response is showing dilatation versus constriction, and see the velocity. In a subtle RAPD, many a times you will see that initially small constriction happens, which is slower, and followed by a greater dilatation, which is brisker. That should raise a suspicion there is a subtle RAPD. And then we can use a neutral density filters. So you put it in front of the normal eye. In the previous example of left eye relative afferent pupillary defect and right eye being normal, you will put it in front of the right eye. Now you will keep on stimulating the right eye. Stimulate it, do the swinging flashlight test, take to the left eye. There will be initially still maybe that pupil is dilating. Then you increase the density of the neutral density filter. As you are increasing it, you will observe that a point will come where the light response from both eyes becomes equal. So that's how you will see that this is the point at which the response becomes equal, and you can get a quantitative measurement of grade of RAPD. So it can be used to both pick up a subtle RAPD as well as to give a value. Any of you have seen this neutral density filter physically?
No. No, sir.
So it is there in our clinics and we use it routinely, and it is something like a small bar, like you have the prism bar like that, but it is dark in color, and on the side the grade is also mentioned from 0.3 to 1.8. That is available in the market easily. Okay, so at least you can remember that how do you do the swinging flashlight test? What are the precautions you will do? You will make the patient see far away. You will use a dark room. You will use a bright light source. You can put a palm of your hand on the nose so that you can actually avoid the light being stimulated to either side. Then you do the swinging flashlight test, and you also know the Bell's grading system. And whenever you get an opportunity to work in any neuro-ophthalmology clinic, you can look for the neutral density filters. Okay. Now there are other devices which have become available, and they can actually give you the value of the RAPD. They are called as automated pupillary analyzers. I will try to show it at the end of the presentation, those also. Okay. There are certain situations where the pupil is actually dilated in one eye and you cannot use if there is only one functional pupil. One of the common example is that there is a trauma to the eye. The patient has got a traumatic mydriasis and you are suspecting that the vision is less, so there should be traumatic optic neuropathy also. Is there a relative afferent pupillary defect still there or not? So what do you do in those cases? What we do in these cases is something what we call as RAPD by reverse, or I will show that through a video in the next slide. What also we can do is that we are basically focusing on the consensual reflex in the eye with the normal people. So suppose the person has got a damage to the right eye, like in this example, this patient had a right eye road traffic accident with traumatic mydriasis as well as decreased vision in the right eye, and the pupil baseline size is larger. So what you can do is that when you use two light sources. One you keep below the chin for providing diffuse illumination to the left eye or the normal eye. You see, then you do the swinging flashlight test. You do the swinging flashlight test first to the left eye and see pupil is constricting or not. Then you do the swinging flashlight test and take it to the right eye. By doing that, you see the response of the right eye is leading to, stimulation of right eye is leading to a consensual response in the left eye. Okay, so let's see it through the video and then we will discuss it again. So you are stimulating the right eye, you don't see constriction. You stimulate left eye, you see constriction. You take to the right eye, again you see pupil is actually dilating. So this patient is actually having a traumatic mydriasis as well as is having a RAPD. Again, I will show the video just to make it clear. You see when the left eye is being constricted, the patient left eye stimulated, pupil is constricting. But when you take from left to right, the pupil dilates. So this is a patient who has a RAPD. So this is called as RAPD by reverse. What happens by stimulating the affected eye? What happens in the other eye? So this is a common technique and examiners are fond of asking that in the exam also. And we use it very often in our clinic. If there's only traumatic mydriasis, but the consensual response is brisk, traumatic optic neuropathy is less likely. Yeah. Okay. I would like to tell it here, but it's not in my slide. I forgot to add that aspect to the slide. Is the size of the pupil, the size of the retinal damage or the size of the optic nerve damage can also give an idea of how much would be the density of RAPD. For example, each quadrant of the retina is believed to cause something like a 0.5 to 0.7 log units of RAPD. If there is a total retinal detachment, it should cause something like 2.8 log units or 3 log units of RAPD. Macula alone is believed to contribute to grade 1 RAPD, which is like 0.3 log unit. If there is an optic neuritis with very low vision PLPR, you can get complete loss of the stimulation and you can get a 3 log unit RAPD as well. So we can quantify, and there is a about, you can also guess what would be the grade of RAPD according to the extent of the retina and the optic nerve involvement. So there is a beautiful table which is there in Adler's textbook of physiology, which gives you that. And I think it is also there in Jacobic's book and might be there in Yanov also, the current edition. So you can go through that table and use that. Yeah. Now, how do you we were talking about RAPD, which we see more commonly. There are certain times where the person actually has an efferent pupillary defect. And what we are actually worried about is that, is it a RAPD or not? So how do you distinguish? So these three images, set of images will tell you how to distinguish. If the person you are doing the swinging flashlight test, you stimulate the right eye first, you see pupillary constriction in both eyes, means that right eye direct response is there, left eye direct response is there. Then you do stimulate the left eye and you see direct constriction again in both eyes. You see left eye direct is there and right eye consensual is also there. It means it is normal reaction. Both eyes are normal. In an efferent pupillary defect, what happens is that the damage is there to the nerve fibers. So the efferent fibers. So whatever eye you stimulate, you will not get the response in that eye. So let's see the middle panel carefully. You are stimulating, the pupil is bigger in the left eye. You are stimulating the right eye. Pupil does not constrict in the left eye, but it becomes smaller in the right eye. So it means that right eye direct response is there, but consensual is not happening. And then you stimulate the left eye direct does not happen, but you can see a response in the right eye. So right eye consensual is present. If you see this kind of response, it means that it's an efferent pupillary defect. In the left eye, where the pupil is larger, both direct and consensual are absent, whereas in the right eye, you can see both the direct and consensual are present. If you see this, it is efferent pupillary defect and not an afferent pupillary defect. And in the third panel, which is the showing an afferent pupillary defect, what you can see that when you're stimulating the right eye, the response is happening in both eyes. Direct and consensual is happening in both eyes. Whereas when you are stimulating the left eye, there is both direct and consensual are absent. So there is no response in the left eye, there is no response in the right eye. If you see this combination, it's a afferent pupillary defect. Again, this is important both for practical exams as well as for your day-to-day practice, wherein you don't get confused with it's an afferent or efferent. So over here, until now, what we have seen is that direct, we have seen afferent pupillary defects, we have efferent, and we have also seen in the previous video, this video, we also saw both afferent and efferent will be there in the right eye of this patient. Okay. So what is ameiotic pupil? Ameiotic pupil refers to the total afferent pupillary defect, wherein you do as much stimulation with as bright light, it does not constrict at all. That is called as a total afferent pupillary defect. Okay. So I will just show a couple of more videos and then we can take any doubts until here before we go to some other pupillary abnormalities. So this is a patient's example, again using infrared imaging. You can see that the person's left eye is being stimulated and there is a poor response. There is a good response in the left eye as well as response in the right eye. And here, when you're stimulating the right eye, there is no response. Okay. So this is a patient where you can see again a good relative afferent pupillary defect, this time in the right eye. Okay. So I'll skip this video. Okay. So we can take any questions until here before we go to a few specific abnormalities of the pupillary pathway. Anybody has any doubts, questions about how to check RAPD, how to check efferent pupillary defect, how to grade the RAPD?
No, sir.
Okay.
You ask questions, no. This is the time you can ask anything. Even if it is silly also, you can ask.
Yeah.
Priyanka.
Okay, it's nice if there are no doubts, but keep in mind.
Sir, I can ask a question, please.
Yeah. Archana, you can.
Yes.
All
Sir,
the,
neutral, yes, sir. Neutral density filter, sir, does it relate in any way to the Bell's grading, or it is independent quantitative measurement only?
Yeah, the neutral density filters will give the values in log units. That's what I was trying to.
So, sir, if we are examining a patient and it has been graded by Bell system, so if the patient, if we receive a patient with neutral density filter measurement, quantitative assessment, and we don't have that in our clinic, then it is not possible to actually elicit it because it doesn't relate the both system.
Yes. So yes, that is true. If it is not there in the clinic, we cannot use it. But it is fine. About grade 1 RAPD corresponds to something like 0.1 log unit. So this will be on the top of the neutral density filter. It will be neutralized by somewhere over there. If it's a grade 2 RAPD, it corresponds to 0.6 to 0.7 log units. Grade 3 corresponds to 1.2 log units. Grade 4 corresponds to about 1.8 log units, and grade 5 corresponds to something like 2.83 log units. This is what is mentioned in the textbooks, and we have also seen in applying both in our clinic. So that's how you can correlate. So if you had a neutral density filter where it would get neutralized, you can expect it to neutralize over there.
No,
Thank you so
Archana,
much.
mainly Bell's grading is a rough grading. It is not definitive grading.
Yes, sir.
Whereas neutral density filter will give you a exact figure at which the relative afferent pupillary defect is there.
We can quantify more accurately.
Yeah.
Yes, sir. Yes. Thank you, sir.
You're welcome. Let's move ahead to certain other important pupillary pathway abnormalities. This is one of them is Addis pupil. It's a important thing that we do see from time to time in the clinic. A person comes to us, we're noticing one of the pupillary size is bigger, or they might have difficulty in focusing in light. Rarely they may complain that there is photophobia. In this example, you can see that the right eye pupil is bigger and the left eye is smaller. So this is also characterized by a few other features. For example, there is sectoral iris atrophy. One sector of iris gets abnormal, there is an atrophic patch, and then it does not constrict. So certain portion of the iris will constrict, certain will not constrict. So that's, if you see directly while simulating on the slit lamp especially, you can see a vermiform constriction. So one portion is constricting, one is remaining like that. So it's like a worm-like movement. That is, these are features which are highly suggestive of AD's pupil. So it occurs because there is a damage to the parasympathetic fibers. Most of the time, it occurs following a viral illness. It has been seen during the COVID pandemic actually, in a few patients, where patients came back with this after having a history of COVID. So there is a ganglionitis that happens in the ciliary ganglion, and that causes damage to the the fibers which are going to come along the short ciliary nerves. So therefore, the parasympathetic impulses would be lost. So what happens in these patients is that because there is damage to them, affected fibers, the sympathetic fibers gets affected. So sphincter pupillae cannot constrict. So pupil will be larger because the dilator pupillary muscle is working. There is poor light response in the affected eye, which is of efferent nature. We already discussed what is afferent efferent, and there is vermiform constriction. In the first few days, there is no other thing that happens. But after 5-6 days, a supersensitivity develops to diluted pilocarpine. We commonly use this to confirm our diagnosis. So what happens is that the pupil is not constricting over there. The acetylcholine, which is there in the junction of the nerve endings of short ciliary nerves and the sphincter pupillary muscle, that gets accumulated. So even if you give a small dose of pilocarpine, like 0.1 to 5%, this would cause a pupillary constriction. In comparison, this dose is not enough to cause a constriction in the fellow eye or the normal eye. So what we do is that we do a dilute pilocarpine test. We take 1% pilocarpine, dilute it, and make it 0.1 to 5%. And then you would put one drop in each eye. After 20 minutes, you will see whether the pupillary size has reduced in the eye where it was previously dilated. So in the classical case, in AD tonic people, what you would see is that after putting the drop, after 20 minutes, this people would have become smaller and might have become even smaller than the normal eye, whereas the normal eye people remains the same. That is a classical supersensitivity test to dilute pilocarpine. In that chronic stage, what happens that this pilocarpine supersensitivity might get reduced because these receptors which were over expressed, they again become quite okay. The number of them, it gets titrated by the body. So in the late stages, after 2 months or so, we may not see this, but what we will see is that the pupillary size is variable. There is poor response to light. There is also poor dilatation in darkness. It is also called as a tonic pupil. It responds slowly. People will be responding slightly. Some areas will be dilating, but they will not be having a brisk response like we normally see. They will be slower. And it also dilates slowly. That is why it is called as a tonic pupil. There might be light near dissociation. There is a slowness of near reflex also, and there is loss of pilocarpine supersensitivity. So again, there is something very important which is told that why this is tonic and why the response is slower. It is possibly believed that because the ciliary ganglion contains lot of fibers, the nerve fibers which are arising in the short ciliary nerves, they are about 85 to 90% of fibers are there for mediating the accommodation pathway, and the remaining ones are for the pupillary light response. So once a damage happens, the body regenerates, and the accommodation fibers, which are bigger, 90% of fibers, they generate. The accommodation fibers have a slower conduction velocity as compared to the light fibers. So therefore, the response is slow. It constricts slowly and it dilates slowly. This is what is believed as a mechanism for the tonic slowly reacting pupils. Okay. Now we go to what which is called as Horner syndrome. We discussed the sympathetic fibers, and at that time also we discussed that if there is damage to the sympathetic fibers, it can cause multiple components. So it can cause ptosis because there is a lack of the innervation to the Muller's muscle. So there is small ptosis. There is meiosis because the dilator pupillary muscle cannot work. So people become small. There is anhydrosis. Why anhydrosis? Because lack of sweating that is controlled by the sympathetic fibers. There is enophthalmos. Again, there are two mechanisms for it. Partially mechanical because there is ptosis, which is pseudoenophthalmos, and then it is believed that uh, there is a lack of stimulation to the sympathetic fibers, which are causing the eyeball to be in normal shape. So eyeball gets retracted a bit. That is the reason for the enophthalmos. There can also be loss of the ciliospinal reflex. What it means, if you pinch on the back of the neck, you can see that the pupil dilates. That is because pinching on the nape of neck or back of neck leads to sympathetic stimulation. And then if this is the problem, the person will have a lack of the ciliospinal reflex. One more important thing which is there in these patients with Horner syndrome is that they can have a ptosis or the upside down ptosis of the lower eyelid. The lower eyelid also has a sympathetic supply. So that's why it is lower down. It's usually below the lower limbus. But if there is Horner syndrome, the lower eyelid goes up and it covers a greater portion of the cornea. That is called as upside down ptosis that might be seen in Horner syndrome. Okay. What about the anisocoria? This patient will have a smaller pupil. So they have small pupil with ptosis and these associated features. If you look at these features, you can diagnose Horner syndrome is likely there. The anisocoria will become more in darkness. Why? Because the sympathetic fibers are going to stimulate the dilatation. So normal eye pupil will dilate, right? But in the eye which is having the Horner syndrome, it cannot dilate. Therefore, it leads to greater anisocoria in the darkness that will be there. So this is an example. Here you can see that in the right eye, there is myotic pupil. There is a very mild ptosis. It's usually about 1 to 2 mm. As compared to left eye, you can see that the left eye, the lid is just at the close to the upper limbus. Here it is going down. We can not appreciate any upside down ptosis over here. Okay. Then there might also be heterochromia that might develop, especially in congenital Horner syndrome. So these are some examples of patients who have Horner syndrome. Fortunately, it is rare. But what is also important, what is classically described, is that we can use certain drugs to diagnose what level of the Horner syndrome might be there. You remember the diagram? We discussed that the first order neuron is a central neuron that goes from hypothalamus to the cervical spinal cord. That is level 1. Then the preganglionic fibers which arise from the cervical ganglion, cervical cord and run to the superior striate ganglion, that is preganglionic, and postganglionic is the ones which are arising from the sympathetic chain and then run all the way upward into the internal carotid artery and go to supply the dilator pupilla. So this is important. This was very much important, the pharmacological testing in the past, because we did not have access to imaging. But at this point of time, many of these drugs are not available easily in the market. So it has not used so much, but Horner syndrome is likely to have certain important diseases. Therefore, it is important to actually do the workup for these patients, and neuroimaging is needed. For the exam point of view, I would try to cover briefly about the drugs which affect the testing in patients with Horner syndrome. First one is cocaine. Okay, cocaine actually acts by blocking the noradrenaline uptake by the nerve endings. So in Horner syndrome, there is no noradrenaline that will be released over there. So what is happening is that whatever the noradrenaline is already present will be used up, and then there will, if you put cocaine in these patients, you cannot get a action. What will happen that the normal people, if you will put one drop of cocaine in either eye, in the normal people it will dilate, whereas in the Horner people, because it cannot act, there cannot be dilatation. So after putting this, anisocoria will increase because the normal people is dilating, but Horner people cannot dilate. This just helps us confirm the Horner syndrome. It does not help in localizing where the lesion is. The drug that helps us in localizing the lesion is hydroxyamphetamine and diluted adrenaline. Hydroxyamphetamine acts by a special mechanism. It potentiates the release of noradrenaline. So in the whatever adrenaline is over there in the nerve index, it will cause it to be released. In postganglionic lesion, the neuron is destroyed. Okay, so hence there will not be release of noradrenaline. Whereas in the preganglionic lesion, where the ganglion cells, where the lesion is affecting the cervical sympathetic chain to the connection to the spinal cord, if there the damage is, for example, in a Erb's palsy, where there is a damage to the upper cervical cord, then over there the person might still be able to get a response. Why? Because preganglionic fibers are affected, but postganglionic fibers are going to contain the adrenaline which is there. So if you put hydroxyamphetamine, normal people will dilate. In the preganglionic lesion, this will dilate, but in postganglionic, there will be no action. Hydroxyamphetamine is also not easily available. So therefore, what is possible to use is dilute adrenaline 0.1%, and it has a very similar action there. Dilute adrenaline acts by a mechanism actually very similar to what we are doing for the dilute pilocarpine. So this will help in dilating the postganglionic lesions, and in the case of preganglionic lesions, it will not act. In postganglionic lesions, there is degeneration hypersensitivity of dilator pupillae to adrenaline. So therefore, after putting this, the postganglionic lesions will dilate, whereas in preganglionic lesions, it will not dilate. And the other drug that can be used very similar to dilute adrenaline is apraclonidine. It acts by acting on alpha-1 receptors, which are present in the denervated pupillary fibers, and that can be used. It is also not easily available. Previously, it was being used in patients to prevent IOP spike after YAG laser. Okay. So any doubt over here about Horner syndrome? Because this is pretty big. There are 3 levels. These are all the features which can occur. And then in addition to that, what we should remember is that there are drugs which can help. They act by a specific mechanism. So they help us distinguish between preganglionic and postganglionic lesions. Okay. Very last thing I would like to tell here is that what is a common approach that you can keep in a patient with anisocoria. So if you are seeing a patient with anisocoria, we want to see that it could be due to 2 things. Either the pupil's sphincter pupillae is dilated, and as a result of that, the pupil has become larger, or the dilator pupillae is abnormal, and as a result, the pupil is become small. So what we do is that simulate the parasympathetic pathway. How we can do? Shine bright light. If the anisocoria is increasing in bright light, that means parasympathetic pathway is defective. Okay. So like in this example, you can see the right side of the image. You can see that anisocoria is increasing in bright light. Right eye is the normal pupil which is constricting, whereas the left eye pupil is remaining the same size. So it increases. So these are the examples of the parasympathetic pathway, like Addis pupil. So it could also be due to pharmacologic mydriasis. Somebody has put the cyclopentolate or atropine drops. It could also occur due to direct damage to the iris sphincter, and it could be due to third dominance. If anisocoria increases in dim light, it means that the sympathetic pathway is not working. Therefore, the sympathetic stimulation is unable to reach the dilator pupillae. So that indicates a Horner syndrome. The other causes being a physiologic anisocoria, which is the most common. So what we do, we look at the patient with anisocoria, we check their responses in red light, and then we take it to the next level. And then we check the other features, like in ADs people, what are the features you see? The segmental construction, vermiform responses. Whereas in patient with Horner syndrome, you are likely to see the doses and hydrosis, and then you can use it. So this is very important. That is an approach to anisocoria. Please try to go through the flowcharts in your books again and try to read it in a couple of days, so you will have a much better understanding of this. Lastly, this is an example of a recently described entity which is called as bilateral acute iris transillumination or BAIT. It has been described in patients who have taken oral moxifloxacin, not the topical drops, but oral moxifloxacin, which is known to cause a hypersensitivity reaction in certain patients, leading to loss of the pupillary responses, loss of the iris pigmentation, causing transillumination defects, and poorly dilating, poorly constricting pupils. So they become fixed. There is loss of the dilator muscles. There is loss of the sphincter muscles. They become like this. And you can also see a hyperpigmentation in the trabecular measure. This is relatively newer entity, which has been also been described. So I think this covers majority of the pupillary pathway abnormalities, practical approach to evaluating the pupils, as well as the common abnormalities that we see in our patients. Thank you for the opportunity to share about this topic.
Thank you, sir. Thank you so much for this exhaustive and a very detailed presentation. I am sure all the PGs have grasped the topic very well, and I'm sure nobody has taught them so well till now. Even I refreshed all my pupillary pathway memories. That was very, very detailed, sir. Thank you. Thank you so much.
Thank you.
For
Thank
the
you for your kind words.
any comments from the panelists?
I would really like to thank sir. Like I echo Dr. Dipti that it's like it was so much that we could learn from it myself. Thank you.
Very, yeah, very exhaustive. And for us who stopped reading for such a long time, so this has become an absolutely a refresher course. Thank you so much.
I have a question, sir. How common is this Horner syndrome? Because I have not yet seen a case.
Yes, actually, Horner syndrome is not uncommon, but it usually goes to the neuro ICUs. That is the thing. For example, the most common types that we see are patients who are admitted in ICU with a acute onset neck trauma or a acute onset acute onset ptosis that might be happening. So they are much more frequently diagnosed by the neurologist, and they come to us much later. What happens that there can be an acute dissection of the carotid, there could be a damage that can happen to the actually the spinal area, and that causes a acute Horner syndrome.
Thoracic
When I was in
tube also.
USA, there were few patients which were coming about one patient every month that was being referred for this evaluation. And while in our own setting, we see patients who have come to us after stabilization. So it is true that it is uncommon. Unfortunately, it is uncommon, but it does come to the neurologist and neurosurgeons much more often than us.
And ADs, what about ADs?
Sorry, sir.
What about ADs people?
ADs people is quite common.
Common.
I think all of us have experience evaluating these.
So do you prescribe diluted pilocarpine for youngs? A lot of sometimes I've encountered young people with Addis pupil and very disturbed with photophobia. So do you
Yes.
give?
We can prescribe dilute pilocarpine. Actually, in the first few months, the patients are more symptomatic, but after a few days, they become okay. They start getting used to it. But there are a few patients who are symptomatic, so you can give them either dilute pilocarpine, or you can we can even prescribe them the photochromatic glasses depending on their
The
symptoms.
longest duration for which you can give pilocarpine? I mean, is there any limitation to it?
Usually there is no limitation to it. The AIDS people does not recover in
Yeah.
majority of patients. In fact, it is described that the other eye may get affected. So there's no limitation to the duration, but most patients give up themselves only because they are not able to tolerate the other side effects.
Thank you, sir.
You're welcome.
Sir, about Horner syndrome, like we get all the myriad of symptoms, clinical features always in these patients.
No.
It's a very good question. The patient can have a partial Horner's and we may not get all the features.
Yes.
Does that relate some way to where the lesion is, or what is the type of dissection?
Yes, again, a very good question. Yes, it does relate. The heterochromia will be seen only in patients who are actually having congenital Horner's. It will not be seen in others. The other forms are like if the lesion is central, again, there will be a little bit more predilection for other features. Anhidrosis may not be seen in patients who have a central Horner's. So these are certain things which are helpful. The patients who have a well-settled Horner's, for example, if there was a CA breast with metastasis to the axillary lymph nodes, or there was surgery done over there, they might have partial features. These are certain things. The worst thing about Horner's is that it could be indicative that acute carotid dissection has happened. One of the common things that is noted in the history of these patients is that they had gone to a chiropractor or somebody or a barber and they had a neck massage, head massage, and the carotid dissection happened. And then they have acute onsetosis. If it is not taken care of that time, from that carotid, the embolus can happen and it can go and cause a stroke. Therefore, within the first week, there is about 18 to 20% chance of somebody developing a stroke. That's why it is very important to recognize and prevent that.
I got very important points. We would actually ask people not to take neck massage.
Yes.
Is it very frequent? So it's common, or with very vigorous massages cause it?
Usually it is uncommon and with a vigorous massage only.
Okay. Thank you so much, sir.
Welcome. The other thing which might be of relevance, sorry, there's some disturbance from the work happening, is that these patients with a child with a Horner's, we should always be aware that they could be having a neuroblastoma. So these are the two emergencies that we should be aware in patients with Horner's. So
Thank you, sir.
Dr. Sabishachi, any concluding remarks?
Excellent presentation on pupillary pathway.
thank you.
Because I think all of us have learned something which we have never learned before. Particularly what impressed me was that 1000, 2000, the timing for testing pupillary reaction in RPD. So I think all of us have learned.
And everyone should have neutral density filters. How much does it cost within that?
It is not expensive. It is something.
Oh, that's what I'm saying.
3,000 something.
Yeah. Everyone should have.
Perhaps
For
it
our
will be
students, at
available.
least we can spend that much.
Sure.
But actually, it's very important, sir, to inculcate and bring it into practice in PG education. And
Yeah, RAPD
we
grading,
are
no.
not used to
Every
it, sir.
examiner will ask.
Yeah. True. So we are so used to these bells grading that we always look upon ki neutral density filter is something really neuro-ophthalmologist should do. But
No,
I
no.
think it holds ground. Yes,
With
sir.
I
ophthalmologist.
think that is more theoretical than practical.
Yeah.
Thank you very much, Dr.
Thank you.
So I think if there are no questions, and let us close. Shall we close?
Yeah.
Yeah. Thank you.
May I
Thank you
request-
very. Yeah, sir. Please.
Yeah, I'd like to request everyone to attend the EIZOC here at Dibrugarh on 11th and 12th. I'm leaving for Dibrugarh tomorrow morning to receive you all there. You're most welcome. Please do come.
Thank you. Thank you, sir. Thank you, Dr. Birender. I think you've given a very elaborate and clinical details about both normal and abnormal people, and I think a lot of learning points the students got. So I thank our panelists and the moderator, Dr. Tripti, for joining with us and staying till the end of the session. And of course, I must thank our president and secretary staying today till the end of the seminar. So thank you very much, and thank you all my panelists and the students. Some of the students could not join, but somehow anyhow, whoever joined, they learned a lot. So I thank everybody, and I'll thank the viewers also for joining this webinar. So thank you all, and last but not the least is our Enter Pharmaceuticals, who is provide the platform. Thank you. Bye. Good night. See you at Dibrugarh. Bye.
Thank you, sir.
Thank
Thank
you,
you and good night.
Thank
Good night,
you.
everyone.
Good night.
Night.
Right.
Thank
Good
you.
night.
Hello.